I finished my undergraduation, which is called the MBBS in Karnataka itself, and it was affiliated to the Rajiv Gandhi University of Health Sciences. I followed this up with my post graduation in psychiatry, and this training happened at the National Institute of Mental Health and Neurosciences,
Right.
also called NIMHANS, and it's an institute of national importance.
Yeah.
Uh, Following this, I set about to do a 1 year fellowship in telepsychiatry, wherein I was responsible for a couple of districts. I think I was responsible for 12 districts, overseeing their functioning, wherein a primary care physician would initially screen patients and then consult with me over a teleconsult to see if that individual had symptoms suggestive of a possible psychological or psychiatric disorder. So it basically involved training primary care physicians to offer first line treatments for common mental disorders. After this, I sat the UK Royal College of Psychiatrists 3-part exam, and I got certified by their board. I became a member of the Royal College of Psychiatrists, which is present in London in United Kingdom. Finally, I went on to do a postdoctoral fellowship specifically in bipolar disorder. So this was a clinical research fellowship in mood disorders, and this happened at the University of British Columbia in Vancouver in Canada. In India, we have a 40-bedded exclusive psychiatric center, uh, which offers holistic and integrative treatment. We also have inpatient care. We generally cater to people with severe mental illnesses, treatment-resistant disorders, specifically in the domain of mood disorders, treatment-resistant depression, treatment-resistant bipolar disorders, substance misuse, and psychosis. Our OPD caters to anxiety and depressive
Yeah,
disorders.
thank you so much, Doctor. I wanted to ask you more about your center in relation to the approach that you take for. So you say it's holistic. So apart from, of course, the medication and the role that the doctors or counselors may play, what other supports do you have in place for patients at your center?
Right, right. That's a very pertinent question, Isha. So our center definitely believes in integrative and holistic treatment. Medications come at the bottom rung of our ladder in terms of treatments offered. First thing that we offer is psychological modes of treatment. We have in-house therapists, lay counselors, and psychiatric social workers. We also have clinical psychologists who work with us on an ad hoc basis, apart from our in-house consultant psychologists. So for anxiety and depression, at least if it is of mild to moderate severity, and if it is not severe anxiety, severe depression with psychotic symptoms, the first treatment that is offered at our center is cognitive behavioral therapy, also called
Right. CBT. Yeah.
talker. Yeah, CBT is what we generally offer to our clients. Uh, that is followed up with supportive work, a lot of supportive work. For example, if a person has anxiety disorder, along with CBT and supportive work, the client is also supported via progressive muscle relaxation exercises. We have an in-house certified yoga therapist who holds the relevant certifications in yoga. And so once this is done, and we see that the patient is partially responding or the patient has completely recovered, we don't intervene with medications at all. Uh, the second rung of treatment at our center is we are big on neurostimulation. There's a lot of emerging evidence in modalities such as transcranial direct current stimulation, repetitive transcranial magnetic stimulation, as well as intravenous ketamine assisted psychotherapy. So this is the second rung of treatment that is offered, basically stimulating specific parts of the brain that have gone haywire across psychiatric disorders. But again, this varies from person to person. This varies from the so-called diagnosis. We all carry our diagnostic labels. So, I mean,
Exactly. Yeah.
yeah, it's very
Um,
important. Yeah, sorry, go ahead.
Oh, yeah. So no, the I guess my next question is if you could shed some light on CBT for people who might not have heard of it before.
Right, right. So yeah, cognitive behavioral therapy in common parlance is called talk therapy. It has two components to it. One is the cognitive part, second is the behavioral part. Cognitive part refers to identifying maladaptive cognitions. By cognitions, I mean thinking patterns. And what happens in a psychiatric disorder such as depression or anxiety is that these thinking patterns become faulty. Hence, our worldview becomes very negative and pessimistic because of our mood state. So, for example, let's say that I'm going through a bad depressive episode. Then, instead of recognizing my strengths, I start focusing my mind, my brain network start focusing on my weaknesses. For example, I might feel unnecessarily guilty. I might feel that there is no hope left for me in the future. So the therapist sort of identifies this maladaptive thinking patterns, faulty thinking patterns, and gently tries to restructure them. Of course, this doesn't happen overnight, and multiple sessions are needed, anywhere between 5 to 20 sessions, and a rational approach is suggested, an alternative pattern of thinking is suggested, and then the client is better able to appreciate that yes, this is not what it is, there is hope that is available, there are uh, I can recognize my strengths. uh, Everybody has strengths and vulnerabilities, so it's all about maximizing the client's strengths and minimizing the client's vulnerabilities. So yeah, CBT basically, uh, the crux of CBT is identification of faulty thinking patterns and restructuring them.
Thank you. Thank you for that. That was very insightful. I suppose my next question is about what you had mentioned earlier about holistic treatment. So you mentioned you have yoga therapy. Have you also, has your center also explored anything similar to art? Because I know when I was going through my own psychosis and also bipolar disorder, I did use yoga as a means of coping mechanism. At
Right.
that time, I had got a yoga teaching certificate from Yoga Institute in Mumbai. But and I used to practice very simple asanas, even in couple of my rehabs in India, which were situated in Gujarat. I would do a lot of yoga. But my question here is, would you recommend meditation for people with psychosis?
That's fantastic, Isha. I mean, it's great to hear of your experience with yoga and with expressive arts therapy. So our center works with these consultants on an ad hoc basis. We do conduct some workshops in terms of expressive arts therapy. Uh, so we have a sister concern as well that caters specifically to people with substance misuse problems, and it is there that we use expressive arts therapy on an ad hoc basis. And you mentioned about meditation. So that's a very tricky question, especially for people who have had this experience with psychosis. So just to clarify for our listeners, psychosis is a state wherein a person loses touch with reality, and the clinical symptoms include delusions, hallucinations, and disorganized speech. So delusions refer to false, unshakable beliefs that are not in keeping with a person's socio-occupational or cultural background, and they are held on with such firm conviction despite evidence being presented to the contrary. So that's a very terrifying state to be in. Then we also have hallucinations, wherein a person can start to hear voices when he or she is alone, and there can be a delusional elaboration of these hallucinatory experiences. So meditation, while it is recommended for illnesses such as anxiety and probably for depression, I personally wouldn't recommend it to people who have had this experience with psychosis, especially during an acute psychotic episode. That would really sort of uh, stress their system out. that will really sort of stress the circuits out. And when you're already hearing these abnormal voices or voices, and you are sort of in a parallel world, in a delusional world, not being in touch with reality. And then when you sit to meditate, first of all, you will not have the the clarity of thinking to sort of to be able to sit in meditation. It requires a very calm environment, both externally and internally. And that is definitely not possible in a state like psychosis. And secondly, there might be a lot of anxiety associated with meditation. Uh, we can start ruminating that one, that I'm not able to concentrate. I'm getting a lot of negative thoughts, and sometimes these voices can command you to sort of engage in acts that are not very pleasant. So personally, I wouldn't recommend meditation. Also, there are emerging studies saying that meditation may not necessarily be very good for people who have had this experience with psychosis. But again, uh, more in-depth studies are needed, more longer term data is required to be able to sort of precisely say whether meditation is advisable or not.
Thank you so much. Yeah, I'm just trying to gather myself and think of it too. Yeah, so I guess you've spoken to yoga therapy because I personally had tried Yog Nidra and it did not work as well for me. Although I felt very refreshed and I thought it would help me go to bed, but it did not. So I guess I would have to agree with you there. My question was, do you consider meditation as a sense of doing things where you put a stop to a flow of thoughts, but it could be even like doing actions such as dance or something else to divert you. So, what alternative do people have who want to take to meditation or spiritual practices for them to cope with their psychosis or any mental health challenges?
You have touched upon a very important aspect, Isha. So we are talking about the concept of flow. We also, all of us have experienced these flow experiences in our lives. For example, for Roger Federer, sitting for meditation is not. I mean, it's not very practical for him. Playing tennis is meditative. It's a meditative experience. Yeah. So for Rahul Dravid, batting in the nets is a meditative experience. So it's not necessary that we view meditation in the traditional sense of the term. Every act can be a meditative experience, and this can come in the form of reading a book or writing a few sentences or even striking a conversation. Being mindfully present and being in the moment without external distractions, that itself can be a very meditative experience. I totally agree with your sentiment that sitting in meditation may not always be practically possible, not just for people with psychiatric disorders, even for people with without psychiatric disorders, with other ailments. Meditation is not quite, I mean, it's not an easy skill. It requires a lot of practice. It requires a lot of effort. So one mustn't lose hope in that situation. There are alternatives uh, to meditation. So we can immerse ourselves in meditative practices. This experience has been very beautifully captured in psychology, and this concept is called flow, wherein one loses the sense of time. For example, let's say that uh, you are a painter, and once you take your paintbrush and uh, engage yourself in that art of painting, few hours would have flown by and you wouldn't have realized. So that is this concept of flow, and that is highly meditative experience.
Yeah, I do I can relate with that because I'm also a Kathak dancer. So I know
Oh
whenever
wow.
I have my prior performing arts degree in that also. Although my riyaz is not as good now, I have my guru here in Toronto, and I learned from Pandita Guru Manisha Sathe in Pune. So
Oh,
I like to keep in touch with the arts, and I although I speak from someone who has had that training briefly in Pune, but so I use that as a coping mechanism. But unfortunately, not everyone has that advantage of having a hobby or a kind of thing that they can use. But definitely, the immersive arts is such a brilliant concept, and even when we talk about Van Gogh and all these such incredibly their art has just been so good, and we see so many people who have been diagnosed with bipolar in the past who have created such brilliant works. And coming back to what you said about uh, sports and players, I really do believe in the power of visualization. So uh, and I know a lot of people do that. I know some people in my family, also my brothers in sports, and power of visualization is so good, even for cricket, where you just visualize something and practice it. Uh, I guess my next question to you, I did see some of your what you had to speak on, how COVID has impacted mental health, and my question to you is, how much do you of a change do you see in terms of statistically speaking, as well as observational, or whatever you want to speak to, in mental health before and after COVID? Do you feel, the second question is, do you feel that this always existed and it's only coming, these mental health challenges always existed, and it's only coming to light now because of the mental health awareness that has started to take form globally? Or do you feel that COVID had to do with really us experiencing those moments because of the environments that were created?
So that's a very relevant question, Nisha. So yeah, I think the epidemic of mental health disorders, mental health difficulties across the globe has always existed, but it's just that it was covered under this lens of stigma. It was covered under this lens of those disorders being ca- totally neglected across global bodies, across the globe. COVID has definitely brought a lot of attention to mental health difficulties, mental health disorders. Although they have always existed in this proportion, COVID has definitely recast them in a new light, and it has brought a lot of global attention to mental health. One of the things that happened with COVID was that it was this pervasive anxiety that each of us experienced. Not necessarily that that person had a diagnosable mental health disorder or mental health condition. All of us went through this global anxiety, so to speak. So that terrifying experience of anxiety, what will happen to me? Will I live to see my children? Will I live tomorrow? Will I be alive tomorrow? So that penetrated the psyche of, across of people across the globe. So then it is then that people really started appreciating that, yes, along with physical health, mental health needs to take priority. Mental health needs to come first. There is no health without mental health. So that realization sort of happened during COVID.
Yeah, thank you for that. I do completely agree with you. Often we always divide the feeling of mental health and physical health. Even for people who have a cut on, or need to put a band-aid on, it's easier that way. Or if
Right,
they run into an accident and say, okay, I have a physical disability, sometimes
right,
it's viewed in a different light when people share mental health
right,
disorders or diagnosis. So I just want to share something with you. So when I came out with my book, I did not realize the implications of it. So
right,
I did, in my own field, I did receive a lot of uh, stigma, which I did not realize that also existed abroad. Because I essentially am in the early childhood field, so I'm an early childhood educator as well, and also doing a lot of advocacy in that work has kind of I think put me at a place where I have made a stand on certain things. But I guess
right.
my question to you is, you had touched upon stigma. Now, for someone who has a diagnosis, and also for other people who I mean, the society in general. How can we together help reduce societal stigma and also self stigma? Because I think self stigma is a very critical aspect which sometimes people do not always talk about. So, what do you have to say about that?
Right. Right. So before I dive into this answer, kudos to your efforts. Kudos to your work. I've seen the kind of work that you've been doing in the field of mood disorders, specifically in bipolar disorder. It's very bold and courageous of you to sort of have this kind of self-disclosure and come forward to shatter the myths surrounding the illness, to shatter the stigma surrounding the illness. As I always like to say, a broken mind is not as simple as a broken bone. A broken bone can be fixed quite easily, but fixing a broken mind takes a lot of effort. It takes a village to fix a broken mind. And
And maybe a village to also break it.
absolutely, absolutely, absolutely.
That's the topic for another day. Anyway, go on.
Right. So when it comes to stigma, see, so one of the things that needs to happen is a lot of discussion needs to happen. Conversations have to start happening around mental health and not just mental illness. So we need to make this distinction between having good mental health and having a diagnosable mental illness. First and foremost, that needs to happen. Secondly, uh, advocacy groups need to be sort of encouraged. NGO work needs to happen, and public figures, people who are in public domains and in the purview of the public gaze, they need to sort of come out and talk about their difficulties with mental health. Now we have seen Olympic athletes, elite athletes, as well as movie stars and parliamentarians coming forward to talk about their experience with mental health difficulties, their challenges. I mean, it's practically impossible that uh, n- uh, it's practically not possible that no one has experienced mental health difficulties. Professionals across sectors, elite performing athletes, all of us go through these mental health challenges. But at the same time, all of us also have this internal strength to cope with these mental health challenges. And our resilience varies from
Yeah.
situation to situation. The coping mechanism varies from an individual to individual. So a lot of conversations need to happen. One of the things that we have that you are propagating is this advocacy, and advocacy work really shatters stigma, Isha. I truly believe in that.
Okay, thank you so much. So you did mention something about resilience. Although I have not studied too much about this, but it does relate a little to early childhood as well. I wanted to get your viewpoints about the famous marshmallow test. If you could,
Right,
I know
right.
that that has to do a lot with the regulation and self-regulation, but if you could just share something about it from a professional lens.
Right, right. So I'm not aware of the kind of literature evidence that is there surrounding the marshmallow test. I think it is beyond my domain of expertise. I think a clinical psychologist would be the right fit to sort of speak on that. But yes, I have heard about it, and I've sort of taken that as well. But I'm not sure the kind of scientific evidence that surrounds it. I'm sure there is, but I am not aware of it.
But even if, for example, what do you feel would in early childhood make or break a child's resilience as they and life course trajectories as they become an adult?
Oh, there's absolutely no doubt about it. All psychiatric disorders are a product of gene environment interactions. And by this, I mean, even if a person has genetic vulnerability towards a psychiatric disorder, mere genetic vulnerability will not result in that disorder getting precipitated or manifested. There has to be an external environmental insult. And this environmental insult very often comes in the form of adverse childhood experiences,
Exactly.
such as childhood neglect, childhood isolation, childhood abuse, both physical and sexual abuse, uh, witnessing parental separation, witnessing the death of a parent before the age of 11 years. So all these are established factors as environmental insults. And these environmental insults precipitates the disorder. These environmental insults also result in propagation of subsequent mood episodes, specifically in bipolar disorder and depression. There's no denying the fact that there's a dynamic and complex interaction between one's genes and one's environment. And resilience is definitely a product of having had a stable childhood. Again, it's a lottery. For example, a lot of us win the genetic lottery. We may not have specific mutations for certain disorders, but a lot of us are not very lucky to have had a stable childhood. Uh, we may have gone through adverse childhood experiences. We may have gone through traumatic experiences. So that definitely shapes our brain's plasticity. So even in scientific research, we have now evolved from talking about gene environment, the plasticity of gene environment interactions. That, we have evolved from talking about the genetics of vulnerability to genetics of plasticity. So we have now started to talk about epigenesis. So
Yes.
this concept is something like stressors will rewire our genes. So if I have had a very traumatic childhood, obviously my genetic structure would have got changed.
So,
It would have got rewired. So now we have also started to talk about exposomes. That is the aggregate sum total of all the stressors, physical, emotional, mental, that an individual has had throughout his life course. So there's no denying the fact that emerging scientific evidence points towards gut dysbiosis, microbiome changes, and all of this we can trace it back to early childhood experiences.
thank you so much for that. So now I wanted to ask you, can we also work backwards when we talk about epigen, whatever
Epigenesis, yeah,
epigenesis? I have heard of this concept. So, but I also have heard of it where we can try to change our environment and in a positive manner to combat these childhood experiences or diagnosis as coping mechanisms. So, how can we influence our uh, brain structures or genes or in a positive way by creating that environment for ourselves, so working backwards, so how you said sometimes that gets influenced, but how can we work backwards and to try to use it
right.
to our advantage?
Right. So let me illustrate this with a case example. Let's say we have an individual currently diagnosed with bipolar disorder.
Okay.
Uh, that person has had adverse childhood experiences in the form of parental separation, and the parent of the child used to physically assault the mother of the child.
So
So let's say that this individual around late adolescence or early adulthood starts having irritable mood, sometimes decreased need for sleep, uh, is generally found to be sort of uh, very irritable, and let's say that an acute mood episode precipitates. So once you've treated that acute mood episode, now a lot of work needs to happen in the domain of psychology, because unless that childhood trauma is worked through,
yes.
it serves as maintaining factor for future episodes. And this needs to happen through psychodynamic psychotherapy, through cognitive behavioral therapy, and a lot of other psychological techniques. And as I have mentioned, we have evolved from the genetics of vulnerability to genetics of plasticity. By that, what I mean is our brain is capable of physically, structurally, and functionally modifying itself in response to new experiences. Yes, let's say that my brain has had a very bad childhood and is exposed to a traumatic childhood. But in adolescence or in adulthood, if I've had positive experiences, the brain is capable of rewiring itself.
So
both
that would
structurally and functionally.
explain so many people who have had those like childhood experiences
Right,
and are now flourishing. So thank you
right,
for that.
absolutely.
Yeah. So I guess my next question, I did have one now. It's
Yeah, yeah. Before you ask,
okay.
so one of the things that I was recently, I think it was, I was going through Larry Ellison's interview recently. He's the founder of Oracle, as we all know.
Mm.
And the anchor asks him, uh, how is it that you have had this kind of success? And Larry goes on to say that I had all the necessary disadvantages set up, which set me up for success. So that's such a beautiful phrase.
Yeah,
That's such a beautiful
absolutely.
way of looking at life.
Yeah, no, I thank you so much for sharing that because I think even in my memoir I do share a quote. I forget whose quote. I think it was either Khalil Gibran or Rumi.
Right,
Correct me if you can, but I mean the ones who have the greatest and deepest scars are the ones who really are born out of that and can
right,
overcome that. So
right,
I really relate to that a lot because I sometimes I feel like either it makes you or it really breaks you in some cases, unfortunately. But uh, to have been through all of that, I feel like I almost feel blessed. You know, there was a little section where and although this part is edited, but essentially I was going to write in the gratitude for my parents to to bless me with this because I know it's a little bit dark, but essentially I am grateful because
right,
at no point have I thought to myself, "Oh my God, why do I have this diagnosis?" And that is actually what was the turning point for me when I accepted it. You know, because I always say if you kind of uh, if 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 my disorder or diagnosis was a person, I would want to hug it and love it. And I think that's the kind of thing that people need to really realize because I think once they do that, it really can be life changing. Uh, Going on, what I wanted to ask you about how you talk about how the family relations and early childhood can play such a critical role, especially when it comes to bipolar diagnosis. My question to you is how can we then, and I'm talking globally, whether it's in India, Canada, or even UK, how then can we uh, collaborate and with the whole like collect collaborative care system which I really believe in. How can we involve the caregivers in in a client's life or a patient's life? And I know that our systems are quite different when it comes to this in India as compared to Canada, but I know of all many caregivers here because I am on few PFACs here, and they really want to be a part of a patient's life, and sometimes that is not always possible, and they have to take permissions to get the parent involved. But how can we work with that to work together to kind of because I feel like once a patient is out, especially after discharge, they essentially have to few of them have to go back to that same environment, which is at home. So then you're back to square one if you're not dealing with everyone you're actually surrounded with. So that's kind of why I also asked that. But
right.
yeah.
Yeah, yeah. So before I answer this question, I just want to extend our conversation from your previous question.
So
You did mention about the kind of challenges that you went through and that how those challenges have shaped you into the personality that you are currently,
yeah.
and how they have really sort of built in that resilience within you. So kudos to you for having overcome those challenges. Uh, you are absolutely right that you are blessed to have experienced and encountered those challenges early on in your life so that you could evolve your own coping mechanisms to sort of deal with those challenges. So this brings me to the concept of anti-fragility, which has been in news recently, and this concept has been propagated by Jonathan Haidt. So he talks of not overprotecting our children. Uh, for example, there's a CNS disorder called multiple sclerosis. And what happens is that there's a theory called hygiene hypothesis, wherein if you don't allow your children to play in the dirt by overprotecting them, don't go there, you'll get your hands dirty and you might sort of catch an infection. Your immune system will not get developed.
It's like
And
risky
once,
play also. They have this
right,
concept of risky play in early childhood.
right, exactly. And once your immune system is not strong enough to deal with those organisms and infections, etc., later in life, it may start attacking itself, the concept of autoimmunity. And so this hygiene hypothesis is definitely talked about in the context of multiple sclerosis. Similarly, if our children are not exposed to the vagaries of day-to-day life, to the day-to-day challenges that life throws at us, then they are shielded from these challenges. So if they can't deal with these challenges head on as children, then imagine what will happen to their brains when they become adolescents and adults. Yes, we definitely need to sort of protect them, show them our love, empathy. All of that is definitely non-negotiable. But if, on the other hand, we overprotect them, we don't expose them to life's challenges, then I think they will not be well equipped to deal with stressors later on in life. So I just wanted to add that perspective
Absolutely,
as
this
well.
is so critical. I do agree, definitely I do agree with you there, and there is a lot of talk is on that topic as well, especially as an early childhood educator, because we have so many parents and caregivers who do
Right,
out of sheer love want to protect their children from those environments,
right,
but often they themselves do not see. Sometimes even exposing them to these challenges can actually equip them to build that resilience. So, if you had anything to say about the role of caregivers and parents when it comes to a client or patient in their life, and also how we can try to get them to be more involved, because uh, I mean, and this is not the case. Like, it doesn't always have to be like this. I know some patients and or caregivers do not want that to happen, but uh, yeah, what do you have to say about that?
So I'll also talk about the role of parents, caregivers' role in helping patient with mental illness, as well as the collaborative care system that you previously asked. So the role of caregivers cannot be overemphasized. It is crucial for a person's recovery. Uh, so unlike, say, a person who has diabetes or hypertension, although the role of caregiver is significant, but in no way can it be compared to the experience of a caregiver who has to give care to a person with schizophrenia, to a person with depression, even with to a person of anxiety. Let's say that I have this frequent panic episodes, panic attacks, and that itself can pose a huge caregiver challenge and burden to my family. For example, on a day-to-day basis, if I have this disabling symptom of panic attacks, obviously my family is going to get worried about that, right? So that itself can take a lot of toll on my caregiver. So when I talk about caregiver in the context of mental illness, one thing, it is very essential to educate the patient's family about the nature of the disorder and the possible course of the disorder. Not just the sufferer himself or herself, the patient's family also needs to know about the nature and course of the disorder.
But
Fa-
what is the role of the parents or the family? Like, what can they do? Because some often it's always on the patient or caregiver. So what role can they play?
One thing that they can do is shatter the stigma surrounding
Sure.
mental
Yeah.
illness.
Mm.
Yeah, you need not discuss this in hushed tones. For example, let's say that I have a family member with an experience of severe mental illness. And I need not sort of try to cover that. What if my neighbors get to know it? What if my other family members get to know it. I need not speak about it in hushed tones. If I can be explicit about it, if I can come out and talk about it, that itself can do a lot of good to the patient, to this person who is undergoing that experience of mental illness. We always talk about, yeah.
Yeah,
Sorry,
that
go
would
ahead.
help with self-stigma as well. I guess that.
Right. That helps a lot with self-stigma. If the person is able to appreciate that, yes, my family is not scared of talking about my suffering, my unpleasant experience, that itself can lend a lot of mental strength to the person who has this disabling experience. Also, I would want to emphasize the fact that we always talk about psychiatric disorders, we talk about patients, but what about the person with that experience? Do we talk about that often? So I'm very mindful of using this in my conversations. I always talk about the person with a mental health problem. Yeah.
Yeah, so I had a question to you regarding, I know a lot of families also do go through a lot when also when, like you mentioned, when when their child or is going through and something. So can you maybe shed some light on certain maybe PTSD that a family might go through who may have been exposed to children who have gone through psychosis? And also, if you could shed some light on why you chose to use the term burden, because I know some people see it as maybe should we use that term or not. So just both those things.
Yeah. So the reason why I use that term person is in the sense is that we need to sort of view the entire concept holistically. I mean, yes, let's say I have depression. Yes, I am a patient with major depressive disorder, but that cannot be my identification alone. Over and beyond that, I will have my strengths, I'll have my vulnerabilities, I'll have my whole persona. It can't be swept under the blanket of just major depressive disorder. That cannot become my identity in and of itself. Beyond major depressive disorder, beyond bipolar disorder, a persona exists. So that's the only reason why I sort of spoke of the person with the experience of that particular person. But having said that, yeah, in some situations that can become tricky. That in itself can propagate stigma, and so that can contribute to that. I'm aware of that. The other question about caregivers having this shock of or you use the term PTSD. Yeah, it can be quite a difficult experience for caregivers. For example, if we talk about substance misuse, by the time a patient seeks help, chronic brain changes would have occurred. And substance misuse, as we all know, is a chronic waxing and waning condition with a lot of inherent relapses, which is the case for bipolar disorder too. Yeah.
Yeah.
Therefore,
No, no, no. I just had a quick question about that. So at what point in history or in the medical perspective, where did the because I know a lot of our centers here are related with, mental health and addictions. So at what point did mental health get tied up with addictions? That's my question. Because I
uh,
know not everyone who's diagnosed with mental health or deals with mental health also deals with addictions.
right.
So you could speak to that.
Right. So, a lot of times we talk of comorbidities when we talk of psychiatric disorders, when we talk of severe mental illnesses. Let's take the example of bipolar disorders. So, comorbidity is the rule in bipolar disorder and not the exception. We have high rates of ADHD, that is attention deficit
Yeah.
hyperactivity disorder. Some studies peg the figure at, I think, between 21 to 7 to 21% have ADHD, but some studies say that almost 60% have comorbid ADHD. Although we can debate on the statistical numbers, we can't deny the fact that ADHD a lot of times is comorbid with bipolar disorder, especially early onset bipolar disorder, wherein childhood onset bipolar disorder, wherein there can be a lot of symptom overlap between ADHD and bipolar disorder.
And what about anxiety disorders? What kind of thing that can overlap with bipolar? Like
Yeah, so yeah,
like a diet?
Right, right. So, ADHD is one of the comorbidities, and we have anxiety disorders, we have OCD, we have eating disorders, we have psychotic spectrum disorders, and we have substance misuse. So, and now some people even have PTSD. So, we have spoken about the entire gamut of psychiatric disorders that can be comorbid with bipolar disorder. So,
And and,
comorbid,
and sorry, I just wanted to ask, out of these disorders that often are tied with bipolar disorder,
right?
out of them, how many can sometimes be born because of a side effect of a medication that you're having for bipolar disorder?
Okay, okay. That's a very interesting question, something that has not been asked before. Yeah,
But it
yeah.
exists, I know it does, so I wanted to ask you about it.
Right, right. So let's take the example of treatment-resistant bipolar disorder. Let's say that we have a patient who has not responded to any prior medication, but continues to have episodes of severe mania. And at that point, let's assume that each and every molecule has been tried. And at that point, we will have to go in for a molecule called clozapine, which we all know is a dopamine receptor blocker, something called an antipsychotic. Uh,
Okay.
Clozapine in some individuals, I think in around 20% of individuals, can result in uh, transient experiences of obsessive symptoms.
Okay.
So obsessions can spring to clinical attention with clozapine. So yeah, but the other disorders that I talked of, eating disorders,
For pain,
PTSD,
you said, yes? Yeah, okay.
sorry, yeah,
Close
eating
up,
disorders,
close the
yeah,
pain.
clozapine, eating disorders, PTSD, ADHD, anxiety disorders. I think uh, not so much. I think it's very rare for medications to sort of, at least psychiatric medications, to result in that. But one thing that definitely comes to my mind is clozapine causing transient obsessive symptoms that is readily treatable once the dose of clozapine is either lower or if an anti-obsessive agent is added or
Maybe
depressive.
we'll have another session on just the medication. Now yeah, because I think it's
Right,
exactly an hour. It's
right,
too heavy. We might have to do it in parts. So
absolutely.
now I'm just gonna like conclude. Thank you so much, Dr. Alok Kulkarni, for meeting with me today. And I am sure that your insights on both research and observational and otherwise it's going to be so helpful for our community. And when I say community, I mean global community. So whether that's India, Canada, UK, if you have any questions, please feel for the viewers, if you have any questions, please feel free to reach out. And there are details in the link listed below, which you can always get in touch with Dr. Alok Kulkarni, who's currently based in India but works from Canada for his postdoc at University of British Columbia.
Just a minor correction. While I am in India and while I continue to uh, have some sort of an affiliation with UBC Vancouver, I finished my postdoc and I'm currently based in India. Thanks for having me on this podcast, Isha. It's been a pleasure talking to you. Your questions were deeply insightful, and I'm glad that we are able to have this conversation surrounding global mental health and bipolar disorder.
Thank you so much.